So, to conclude our academic journey, so we now turn to a real world case capsule. So, again, this is a very new initiative in our webinar. So, we will be not only discussing about the lectures, rather, the bedside management of a critical case pertaining to the webinar that we are having. So, with me, Dr. Priya Logia, consultant in critical care from MGM Hospital, Chennai, India. Now, she will be presenting a high stakes sepsis AKI case and walk us through the decision making that changed the outcome.
Greetings, everyone. Proud and honored to be a part of this forum. Hope I'm audible.
Yeah, you are audible.
Thank you to the Nephrocritical Care Society. So, sepsis associated AKI, a case scenario, how we managed. So, before going into the case scenario, Saki is defined as acute kidney injury as per the KDIGO criteria in the context of sepsis. As per the sepsis 3 criteria, within the time frame of 7 days from the diagnosis of sepsis. So it carries a significant health burden, increasing the mortality, and the risk of chronic kidney disease increases by threefold. So understanding the pathophysiology is very, very important because this is a heterogeneous syndrome with multiple mechanisms. It can be immunomodulation, inflammation, complement activation, RAS dysfunction, mitochondrial dysfunction, metabolic reprogramming, microcirculatory or macrocirculatory alteration. So, understanding these mechanisms, we can subtype them, the subphenotypes or the endotypes, which will be very helpful in understanding the sepsis and the AKI trajectories and will aid in targeted management. Sepsis induced AKI is a subtype of sepsis associated acute kidney injury. So, this involves the mechanisms predominantly involved in sepsis per se, whereas sepsis associated acute kidney injury involves the mechanisms that includes the nephrotoxic drugs and the fluids that we give. So coming to the case scenario, so this is a 62-year-old woman who presented with fever, productive cough, shortness of breath, decreased oral intake, and reduced urine output for the past 3 days. She was a known diabetic for the past 10 years with a poorly controlled sugars. She was a hypertensive as well. She was a COPD patient and she was on the medications metformin, ramipril, and nebulizations. So in the ER, she was found to be hypotensive with a BP of 7640. She was clearly tachycardic with a heart rate of around 120. She was tachypneic. She was febrile. And she was severely hypoxemic with a saturation of 80% on a non-rebreathing mask. She was barely responsive to commands. Her GCS was E2, M5, and V2. She had cold motile skin and a capillary refill time were more than 3 seconds. She had coarse crepitations on auscultations. So these were the laboratory investigations. The infective parameters were elevated. The white cell count was 22,000. The CRP procal was elevated. The blood urea nitrogen was 120 milligrams per deciliter. The creatinine was 4.2. She had high sugars at presentation. And the blood gases revealed a severe metabolic acidosis and a severe hypoxemia with a PF ratio of less than 150. The anion gap was elevated. Further investigations, the urine analysis showed a mild proteinuria and hematuria, and the renal ultrasound revealed normal sized kidneys with the corticomedullary differentiation that was preserved. There was no hydrouretronephrosis. The echogenicity was mildly increased, and she was clearly oliguric. So further, the chest X-ray showed bilateral diffuse patchy infiltrates that were suggestive of ARDS, secondary to pneumonia, and the echo showed a normal RV and LV. The IVC was clearly collapsing. So further clinical course, in the emergency, she received IV fluids almost 1.2 liters of crystalloid based on the fluid status of the patient. It was individualized, and she was started on norepinephrine infusion, and she also received IV broad spectrum antibiotics. So, because of the hypoxemia and low GCS, she was intubated and and placed on mechanical ventilatory support with a lung protective ventilation of volume control mode with a tidal volume of 360. Her FiO2 requirement was and PEEP requirement was very high, and insulin infusion started to achieve glycemic control. The nephrotoxic medications were avoided. Ramipril, metformin discontinued. She also received anti-hyperkalemic measures. So clearly, the patient had the following steps: sepsis early recognition, optimal fluid resuscitation, early antibiotics, and the nephrotoxic drugs were avoided. So, further monitoring of the kidney function is traditionally done with the help of urine output and creatinine. The biomarkers have a significant role. Combining the damage and the functional biomarkers enhances the sensitivity and specificity. The various biomarkers help in identifying the mechanisms and the etiology. They help in phenotyping. They help in identifying the different stages and help guide and management of these patients. So it also helps to predict persistent and progression of AKI, and it can help in identifying the patients who will need RRT and facilitate optimal timing of RRT initiation. It has a role in prognostication and outcome. But this is an area of major future research focus at this point. Based on the availability and the cost constraints, the biomarkers can be applied. Bedside Doppler ultrasound can assess the renal perfusion. Renal resistive index can also help in predicting persistent AKI. So the urine output and the creatinine was monitored. Our management plan included sepsis management, which included the sepsis 6 within 1 hour, which was clearly done, and further AKI management with stopping the nephrotoxic drugs, avoiding hyperglycemia, monitoring the renal parameters, including the urine output, urea, creatinine, electrolytes, and the acid base gases. So, day one in ICU, the patient was put on lung protective ventilation. Lines were placed, the central, arterial, and the right IJV dialysis catheter. Fluids were administered carefully based on the fluid responsiveness and the tolerance, and vasopressors titrated to maintain a mean arterial pressure. The drug dosing was done as per the creatinine clearance, and because the patient was clearly hypoxemic despite maximal ventilatory support, the patient was prone. So, day two in ICU, there were clear indications for renal replacement therapy, which was persistent metabolic acidosis, oliguria, and raising urea creatinine levels. And also, the FiO2 requirement was raising, which denoted a fluid overload status. And the patient was initiated on continuous renal replacement therapy. So, the mode was continuous veno-venous hemodiafiltration was prescribed with an effluent dose of 20 to 25 ml per kg per hour with a blood flow rate of 150 ml per minute, and ultrafiltrate was titrated carefully to avoid hypotension. Anticoagulation was done with heparin. So clearly, the urine output was monitored, daily creatinine levels, blood urea nitrogen, lactate levels were monitored, ventilatory settings adjusted based on the blood gases, regular check of the CRRT circuits was done, and close observation for signs of recovery. So improvement in the hemodynamics, decreasing lactate levels, and improving urine output was also observed. So day 4, by this time, the patient had 2 sessions of proning of total duration of 36 hours. The lung compliance, oxygenation, and hemodynamics improved. The patient was placed in supine position and CRRT was continued. Day 5, the hemodynamics stabilized. the vasopressor requirement came down, the lung compliance improved, and CRRT was changed to intermittent hemodialysis as and when indicated. Gradually, the urine output improved. So, day 8, the blood urea nitrogen had come down to 50 and the creatinine levels had improved to 1.3. This stage, we had considered diuretics, de-escalation of fluids, as well as the antibiotics to facilitate early weaning, and the patient was extubated successfully on day 9 and transferred to the step down unit for rehabilitation on day 12. The renal parameters at the day of discharge, that was on day 20, was a blood urea nitrogen of 35 and a creatinine of 0.8 with adequate urine output. So, what led to the improvement in this patient was a timely, appropriate, multifaceted approach. So, a concise summary of what were the steps that was followed in this patient. So, as the patient presented, an initial assessment and investigations were done, and a diagnosis was immediately established, with lung being the source of infection, septic shock, ARDS, and stage 3 acute kidney injury. The initial management was appropriately initiated in a timely manner with IV fluid, which was personalized to the patient's status, and antibiotics and vasopressors implemented. And the patient was immediately intubated. These facilitated appropriate perfusion and oxygenation to the organs. So at this stage, biomarkers play a role for identifying the different endotypes, and targeted management can be done. Immunomodulators can be considered. Extracorporeal therapy can be individualized based on the patient's status. So, despite adequate management, the patient AKI worsened, and then the patient was initiated on renal replacement therapy. And with the adequate supportive care, the urine output, electrolyte, as well as hemodynamic gradually improved, and the patient was weaned off RRT and ventilator and was shifted to the step down care. So, the key learning points are: early aggressive management of sepsis prevents multi organ failure. Measures to improve renal perfusion and oxygenation should be considered in a timely manner. Incorporating biomarkers to guide diagnosis and management plays a key role, and timely initiation of RRT when indicated. So always apply the AKI care bundles. Thank you.